Hello, Ms. Kofke here, coming to you to talk today about urinary elimination. So we're going to talk about that genitourinary or GU, you'll hear the term assessment. So thinking about urination. The other word we'll use is micturition. So we'll be talking about that. So we're going to be looking at assessment findings. So how often is somebody urinating? What is the color, consistency, odor, characteristics of the urine? What is the patient experiencing when they urinate? Are they having pain, urgency, frequency? So we're going to look at all that, thinking about what is going to impact urinary elimination as far as fluid intake, whether there's a lot of fluid or not a lot of fluid, with the functioning of the kidney, and what you might expect to find. You should have watched in your module, there was links for 2 A&P videos, an anatomy and physiology, 2 basic pieces of that urinary system. I would highly suggest watching those. I know you've all had anatomy and physiology, but kidneys are so complex and they have so many functions, and it is so important to your body that they work correctly. So I would definitely look back at that to get a good understanding of how that's working. There's also one on the angiotensin-renin formation and system. That's really good as a reminder of that. And this will also be helpful, that piece, that angiotensin and renin will also be helpful when you start going over some of those vasoactive medications in pharmacology. So let's look at what your urinary system is responsible for. So they're responsible for all sorts of things: red blood cell production, fluid balance, some other things we'll get into in just a minute. So the functional unit of the kidney is called the nephron, and there's about 1 million of those in your kidneys. They will filter waste and eliminate toxins, excuse me, excess ions and water from the bloodstream and excrete them as urine. So the kidneys help regulate fluid balance by regulating the amount and the makeup of the fluid inside and around the cells. So they're going to help if your fluid volume overloaded, they're going to help get rid of extra fluid. If you don't have enough fluid volume on board, they're going to try to hold on to extra fluid. They also aid in red blood cell production by excreting erythropoietin, which is the hormone that stimulates red blood cell production in the bone marrow. They regulate vitamin D and calcium formation by converting vitamin D to its active form to help with calcium and phosphorus balance. They also regulate your blood pressure by producing the renin, and then that goes into your angiotensin system. So it produces the renin, which then will help form into angiotensin 1, then converted to angiotensin 2, which will then increase your blood pressure because it will constrict your peripheral vessels. So it helps with blood pressure control. Also, you have hormones that will help control fluid balance, your antidiuretic hormone, and aldosterone that helps monitor blood volume. So it also will then figure out about electrolyte concentration and acid-base balance. So lots of things going on there. So one of the things that I feel like gets confused a lot is the difference in fluid and electrolyte imbalance or fluid balance and elimination. So if your patient's dehydrated and they're not urinating, that's not really an elimination problem. That is a fluid balance problem. So that's Ms. Curley's fluid balance content there. That's a fluid and electrolyte issue. So where elimination is actually, we're actually thinking of excreting urine and the actual process of getting the urine out after it's formed, not actually whether or not your body has enough fluid, that's a fluid problem. So elimination is going to be a problem. Discomfort, frequency, we'll look at different things that are alterations in that actual process of elimination. So if your patient has an elimination problem, it's not the problem of making urine, it's the problem of getting rid of it is altered in some way. So I hope that kind of helps make sense of that. So let's talk about that. Let's talk about urinating. So it is known as micturition, as I said, or voiding is another term that we use, but it is basically the emptying of the bladder. Stretch receptors in the bladder are stimulated as urine collects inside the bladder. About 150 to 200 mLs is usually when a person will feel the urge to void, when those stretch receptors say, hey, we got a lot of urine in here. So at about 200 to 450 milliliters of urine in the bladder, that will cause that bladder distension to activate receptors in the bladder wall. The average bladder can store about 500 mLs, but can usually extend to 2 times that amount if needed. So about 1,000, and then you're getting at risk of damage. So, but typically a normal bladder can store about 500. Normal urine production is about 60 to 120 milliliters per hour. Normal is that the urine should be pale yellow, straw colored, or light amber, and it typically has a slight ammonia type of odor, because that's one of the things that we're excreting is ammonia. So let's look at some terms that reflect alterations in that. So box 37.1 in your fundamentals book does go into details about these. You do need to know these terms. These terms are used regularly when we're talking about urination. And this isn't some fancy words that we're only teaching you in nursing school. This is the terms that you will hear in clinical. So anuria is a urine output of less than 50 mLs in 24 hours. So almost none, basically. So very tiny amount, less than 50 mLs in 24 hours. Dysuria is going to be painful or difficult urination. Frequency means that you are going more often than what is considered normal, like you're having to go a lot more often. We'll talk about some things that can impact that. Nocturia means not that you're, you might think that knock means nighttime, but it doesn't mean you're incontinent at night. It means that you are having to wake up at night to go to the bathroom. So it interrupts your sleep cycle. Oliguria is scant urine output, so less than 400 mLs in 24 hours. Polyuria is excessive urination. Urgency is the strong desire to void. Hematuria, blood in the urine. Pyuria would be pus in the urine. So we've got our image here. Anuria, oliguria, normal, and polyuria. So let's talk about some factors that affect urination. So there are developmental changes that will impact urination, and we're going to talk about those in later slides. Food and fluid. So when your body is dehydrated, your kidneys are going to reabsorb more fluid to hold on to more fluid. So then your urine becomes more concentrated. When your body is in fluid overload, your body's going to try to get rid of extra fluid, as long as your heart is perfusing enough blood there, and your kidneys are working well enough to get rid of it. Then your body is going to excrete that extra amount of dilute urine. Substances with caffeine, like coffee, tea, cola, and chocolate, can increase urine production. Alcohol also has a diuretic effect and increases urine production. So the alcohol and caffeine inhibit that ADH. So the ADH is the anti-diuretic hormone. So it keeps you from diuresing. It holds on to fluid. if it's being suppressed, then you're going to have more diuresis, more fluid coming off. Foods with a high sodium content will cause reabsorption and retention of fluid, a decreased urine output. Some foods can change the smell of your urine, like asparagus or onions can affect the odor of your urine. Psychological factors. So this, I always think about with cultural differences or different genders, people being uncomfortable trying to urinate in front of people. And as nurses, we need to do our best to be sensitive to that. We want to put our patients' safety first. So if you're ambulating somebody to the bathroom, you need to make sure that they are safe. That's going to need to come first, but do the best you can. If people have a hard time urinating in front of people, to give them the privacy they need while keeping them safe. Prolonged periods of immobility can result in poor urinary control or in urinary stasis. Clients with mobility issues may not be able to get to the bathroom in time also. So may cause the patient to have some problems getting to the bathroom in time and some moisture related problems if they are required to change their clothes more frequently. Pathologic issues. So urine can become concentrated and low in volume as the body's response to save urine in a dehydrated state. Kidney failure. So people with if their kidneys aren't working, remember back a few slides ago, we talked about all those things kidneys do. Well, if kidneys aren't working, then they're not going to be able to regulate that fluid balance. Fever and infection can also result in decreased urine output because the body's trying to hold on to that extra fluid. Pregnancy can decrease the muscle tone in your bladder. And then also, if you have indwelling catheters for a long time, it will also cause the bladder to lose its muscle tone some. Other things, things with the nervous system, like after a stroke or spinal cord injury, patients may not be able to perceive bladder fullness or control that urinary sphincter. Or the bladder may become either flaccid or just completely where the muscles don't work at all, or spastic, where it's just uncontrolled movements. We also have the issues that will affect elimination of communication. If somebody can't tell you that they need to go to the bathroom or when they need to be able to urinate, even if they are able to feel it, that they can't verbalize that to you. Cognition can alter the perception of the urge to void and can lead to incontinence. And then cardiovascular disorders decrease blood flow and perfusion. If your heart's not perfusing, then you're going to have decreased blood flow through those glomeruli, and that will impair filtration and decrease urine output and cause that. That's why if your heart and congestive heart failure, or your patients that have poor perfusion, why that edema happens, because there's not enough blood flow and perfusion pushed through those glomeruli. Medications that can impact your urination. Anticoagulants could cause blood in the urine. Diuretics can cause the urine to be less concentrated because it is causing there to be an increased, it's trying to pull fluid out in that glomeruli and decrease that reabsorption of water back into the blood system. It's keeping that in the urinary system so it's excreted. So it will decrease the concentration or dilute your urine, and it'll appear very light yellow to even very close to clear. Pyridium will help to relieve pain, burning, urgency, and frequency during UTIs or urinary tract infections, which you learned about in the last unit. But it can turn your urine orange or red colored. Antidepressants can also cause your urine to turn green or bluish green, as well as vitamin B can do the same thing. And then levodopa, which is used for Parkinson's, and iron supplements can cause your urine to be brown or even a black color. So let's talk about urinary elimination in children. So toilet training is influenced by lots of different things, family and cultural norms. If you have older children, sometimes it can influence younger siblings. They may potty train a little bit sooner because that's what the norm is in the family. Most children in the US begin toilet training between 18 months and 36 months, so about 1.5 to 3 years old. Some cultures don't expect to begin toilet training until the child reaches 5 years old. So it really depends on the culture and the family norms. So some key factors to know when it's ready to begin toilet training is that the child should be able to hold their urine for at least 2 hours. That tells us they can control their urethral sphincter and feel the urge to void. They also need to be old enough to be able to communicate that they need to void. And then as far as tactile skills, they should be able to remove their clothing to void. So all those pieces need to be in play. So as the nurse, things that we need to reinforce or teach to a child is to remind them to wash their hands and flush, and then instructing on wiping front to back. Enuresis is occasional wetting, and it's normal and not really considered a problem until after the age of 6. So this is occasional wetting. It's normal until after the age, it's not considered a problem until after the age of 6. It's normal, and it usually occurs when a child is playing, when they're intensely involved in something and they're not focusing on what's going on, or they don't want to take a break to go to the bathroom, or they're so involved in what they're doing that they don't recognize that urge to void. So we need to teach parents that this is normal. We are not to punish, not to punish the child, as that can place negative connotations related to going to the bathroom. So it can occur when a client who has previously been dry throughout, and so then, nocturnal enuresis can occur when a client who's been previously dry throughout the night has episodes of enuresis at night. So this is typically due to illness or stress. Nursing interventions, we may limit fluid. We want to educate on limiting fluid intake in the evenings. We can also use a reward system for the child. And then for enuresis during the day, we can encourage frequent urinary training, emptying the bladder every 2 hours on a schedule, so that they don't get so involved with what they're doing that they don't go to the bathroom. So just like with all the other things that we teach, we have the young end of the spectrum, and then we have problems with the other end of the spectrum as far as age goes as well. So the most important functional deficit caused by aging is a decline in glomerular filtration. So decreased kidney function already places older adults at risk for drug toxicity because they're not excreting as much of the medications, and they're taking more medications. So the kidneys physically will decrease in size starting at about age 50. This will lead to frequency due to decreased functioning in those neurons. We also have arteriosclerosis, or hardening of those arteries. So that reduces blood flow to the kidneys. There's a loss in muscle tone in the bladder. The wall becomes less elastic. So that can lead to nocturnal frequency and needing to get up during the night. The decrease in muscle tone can also cause the bladder to have a decreased capacity to hold large amounts of urine. So that can also lead to urinary retention after voiding. And then that will increase the chance for infections because of that urinary stasis. That urine just sitting in the bladder can then start to grow bacteria. Neuromuscular problems can affect that voluntary control of the bladder and the ability to reach the toilet in time. Medications such as diuretics will increase urine production. Urge incontinence, we'll talk about, is the involuntary loss of urine that occurs after feeling an urgent need to void. So if you feel like you need to go to the bathroom and you know you need to go, but you can't get there in time because all of a sudden it's like when you have to go so bad and you can't make it there. So that nocturia, the incomplete emptying of the bladder, and that stress and that urge incontinence will happen as a result of loss of bladder elasticity. Also, in males, we have prostate enlargement in the elderly, and so that can cause frequency in urination, hesitation, or difficulty to begin urinating, and reduced force of the stream. And so they may experience dribbling or nocturia, or some urinary retention with that. Okay, so let's talk about some of the urine studies that we'll look at and how we study them. So a UA, or a urinalysis, is a urine specimen that is collected using aseptic technique. Typically with a urinalysis, we'll actually talk about it in a minute about how we collect it. But it can detect or measure several different substances in the urine, as well as byproducts of normal and abnormal metabolism. It can look for cells and cell fragments as well as bacteria. First up, your specific gravity. So your specific gravity is the concentration of solids in the urine, such as protein or blood in the urine. It's going to be increased with dehydration. So thinking about things that could cause dehydration. Also with liver or heart failure. So when you're thinking about that specific gravity, think about gravity or like weight. The more concentrated it is, the heavier it's going to be. So that's going to be a higher specific gravity, heavier, higher. So higher specific gravity with concentrated urine. It is going to be decreased with if you had a fluid volume excess or if you took a diuretic medication. So if your diuretic medication is making you get rid of extra fluid, it's going to be it's going to be more dilute and less concentrated. So it's going to be less, it's going to be lighter, it's going to be less dense. So you can also, when you do in your analysis, inspect for color and odor. They'll also look for the pH of the urine, presence of red blood cells or white blood cells. And then the osmolality of the urine is going to that osmolality is going to kind of help determine the ability of the kidney to dilute urine. So when these last bits starting at clean catch are going to talk about different ways of collecting the urine. So when you're doing a urinalysis, you only need about 10 mLs. It's not a whole lot. If your patient is menstruating, that needs to be written down on the lab strip because that could be so that they don't mistake menstruation for blood in the urine. So a clean catch urine is obtained, and if you're just doing a urinalysis, Typically, this is what you're going to see is just a clean catch in somebody that's continent. So they'll be instructed to clean the genitalia from front to back carefully before voiding, and then we'll cut and then to catch the specimen midstream. So not as soon as you go, as soon as you start voiding, but to begin voiding and then collect the urine midstream. If you need a sterile specimen, then that would need to be done as an in and out catheterization. That's going to be usually if you're doing a, sometimes they'll do this if they want to make sure that it is sterile if they're doing a culture. So if it is done sterilely, we need to get it directly from the bladder. So typically, you may be doing it as an in and out catheterization, or you may be getting it from a Foley catheter. Now, hold on, I'm going to pause this for a second and unshare. Okay, so if you're collecting from a Foley catheter, you are not going to collect it from this bag down here. This bag has been hanging down by the ground. It's been holding just urine, just sitting in it for long periods of time. It's not sterile. It can have bacteria in it. So where you will get it from, if you're doing it from a Foley catheter, is this port right here that connects to your drainage bag from your catheter. You will set this to kink this tubing for about 30 minutes. And then I can use my syringe here. So that some urine collects there. After you've had some urine collect, again, you only need about 10 ml, so not too much. You would then use your alcohol swab because we're getting a sterile sample. So we want to make sure we clean this really good so that we don't have any bacteria on this hub. So you would clean this really good, scrub the hub, scrubby, scrub for like 15 seconds, about 15 seconds, and then you can screw a syringe directly onto that. Now, there are some urine specimen syringes that when you would pull back, you would collect your urine, and then this piece here like will snap off, and then you would put a sterile cap onto the end of this. Some facilities, you may just use your 10cc syringe and put a sterile cap on the end so it doesn't squirt out in your specimen bag, because lab would not appreciate you if you sent down a bag of urine. And then make sure you unkink your tubing. Label, put a patient label directly onto it, date, time, and initial. And also you'll have to indicate the source of where you got the urine. So it would be from the Foley. Point of care testing would be done at the bedside with strips. So it would be just even in the hat where you would collect the urine and you just dip your stick in to look for different things. So it may look for glucose, it may look for protein, different things just there at the bedside. 24-hour urine specimens will help to determine specific kidney functions. So you would determine a start time for collection, and you would ask the client to void. That first time they void, that'll be discarded. So you would choose the time, they would void at that time, discard that urine, and then all the subsequent urination for the next 24-hour period would be collected. Until the stop is still that until that stop time. The last urine would be collected at that stop time. So the urine does have to be kept cold. So patients that are getting a 24-hour urine sample, you may see that their collection thing is in their room in a tub of ice. Sometimes it's a lot of times what you'll see. Okay, so now we talked about some urine studies. So let's look at blood studies. So I bet in clinical, you have looked at BUN, or blood urea nitrogen, and creatinine. So let's talk about those. So the BUN, or blood urea nitrogen, measures the nitrogen fraction of the urea. So it's a byproduct of protein metabolism. And so it is influenced by other things besides just kidney function. So creatinine it will help you determine kidney function because that byproduct should be eliminated. A lot of it should be getting eliminated, but there are other reasons why you may have an elevated BUN that don't have to do with kidney function. So that's why creatinine is going to be more reliable as far as if you're looking strictly at kidney function. Medications like aspirin and antibiotics can increase the BUN. Like I said, it's a byproduct of protein metabolism. So it can be influenced by diet and fluid intake. Some causes of increased BUN that don't have to do with kidney function is if somebody had a high protein intake, if they had some sort of a febrile illness, because it can cause tissue breakdown, so increased protein metabolism. Dehydration is a big one. So an elevated BUN and your creatinine is normal, a lot of times that's a big sign of dehydration. So that's going to be some of your big reasons. With the creatinine, that's going to provide your best measure of renal damage and renal function. Creatinine is a waste product that's produced by muscles from the breakdown of a compound called creatinine. So it should be removed from the body by the kidneys, which filter out almost all of it and release it into the urine. When kidney damage increases, it's not getting filtered out, so that blood creatinine level will go up. As I said, that's why it is a better indicator of renal function, the BUN, because it doesn't have so many other factors involved. Normal creatinine is going to be, typically there's different values for men and women. What you see as an overall is that male value, 0.6 to 1.2. Make sure you're using your facilities numbers as well. And then that normal BUN range is about 7 to 20. GFR has to do with, it is the glomerular filtration rate. So how much blood is being filtered, the rate that things are being, blood is being filtered through the kidneys, the amount of filtration that's happening in the glomerulus. So GFR is going to tell you about kidney damage. So about 100 to 120 is what's normal. Anything below 60 though is going to indicate kidney damage. So the lower the number, the more the damage. So think about it's how much is being filtered. So if you don't have very much, you're not getting the filtration that you need. So lower numbers are bad, higher numbers are good. So less than 60, and so it may be an acute problem. Remember, we've got acute issues, but if you've got it GFR of less than 60 for 3 months or more, then that's going to be a sign of chronic kidney disease. Less than 15 is a sign of kidney failure. If it is less than 15, then you're looking at a patient that cannot clear the things that they need to and produce urine as they need to get rid of waste products. So let's look at other diagnostic tests. That IVP is an intravenous pyelogram. Let's see, let me put it in a little text box. Oh, sorry, let me put that in a text box over here. Oh, that's not what I wanted. My goodness. Okay, here we go. That IVP, put it up here beside it. Okay, I'm going to move forward. Intravenous pyelogram is an X-ray examination of the kidneys, ureters, and the bladder, and it uses iodized contrast material injected into the veins. So that contrast material is injected into the vein, and then it travels through the bloodstream, and it collects in the kidneys in the urinary tract, and then they can take X-ray images of it. So it allows visualization. of the kidneys and the function and how they're functioning along with the ureters and bladder. It's used to help diagnose symptoms like blood in the urine or flank or lower back pain. It can help identify problems like kidney stones, enlarged prostate, tumors in the kidney, ureters, or bladder. If there's scarring from UTIs, recurrent UTIs that could have caused scarring, or any congenital anomalies or things that were wrong from birth with that urinary tract. Typically before this procedure, the client's NPO, it is contraindicated for patients with elevated BUN and creatinine levels. So they need to have normal kidney function in order to have this test. The reason for that is because of that contrast dye. It will damage your kidneys. And so you need to have normal kidney function to get it flushed out. Otherwise, it can be nephrotoxic if your kidneys aren't able to get rid of it. It can cause worse damage. They may give a laxative before or an enema prior to the procedure so that stool and gas don't interfere with visualization. And food and fluids can be given immediately after. Another test is a cystoscopy. With this, a thin tube with a camera, it's kind of like an endoscopy, so scopy camera. So cystoscopy, looking at the bladder, a thin tube with a camera with a light on the end is inserted into the urethra. It can be ordered for blood in the urine to look for causes, frequent UTIs, overactive bladder, or pelvic pain. It can also be used to treat some underlying bladder conditions. Surgical tools can be inserted through the scope to remove small bladder tumors or stones, or to get a sample of bladder tissue. Liquids are typically allowed the morning of the procedure. Sedation may be given during the procedure to help the patient to feel more at ease. Afterwards, it may be normal for the patient to have a burning sensation while urinating for 2 to 3 days. They may have to urinate more frequently than normal. Remember, you just put a tube in their bladder, so it may have caused some irritation and inflammation there. Blood in the urine may be common after the procedure, especially if they did a biopsy. So we're going to encourage these patients to increase their PO intake and drink lots of water. The more they're drinking, it's going to flush that out and help with that burning and bleeding. We're going to monitor the patient for a fever higher than 100.4, or if they have bright red blood or clots, that may be an issue though. So a little bit of bleeding, mild pink discoloration may be okay. Bright red blood, not okay. Clots in urine, not okay, because those clots can then block your ability to urinate. So if you're unable to void, that's going to be an issue and probably going to need to get a Foley catheter in to drain that bladder. So if that patient is unable to void after a cystoscopy, you will probably want to do a bladder scan to see if they've got some urinary retention from the inflammation or a blood clot blocking that urinary exit. So we'll need to be monitoring eyes and nose closely on these patients and monitoring for any persistent stomach pain, because that could be from urinary distension or bladder distension. Renal biopsy involves taking one or more tiny samples to biopsy from the kidney. The biopsy may be obtained percutaneously or through the skin, where a needle is placed through the skin that lies over the kidney and guided to the right place, usually with the help of an ultrasound. Or they may do an open biopsy, and that would be done if they were already having surgery and the kidney was visible. Then they could get a sample of the kidney during surgery. Biopsies may be done to look for causes of blood or protein in the urine, abnormal blood test results, acute or chronic kidney disease when they don't know the exact cause, nephrotic syndrome or glomerular disease. So they're looking to see what's happening in the glomerulus and what kind of damage is there that's causing the kidneys not to function appropriately. So before the procedure, you would need to obtain coagulation studies. Patients should not take aspirin, over-the-counter pain medications, or NSAIDs, or any blood thinners, anticoagulants of any kind. Remember from the video with the overview of the anatomy and physiology of the kidney, they are highly, highly, highly vascular. So increased risk for bleeding. So nothing that's going to increase that risk. NPO for 8 to 12 hours prior to the procedure, and then sedation may be given at the time. After the test, clients should lie still for about 4 hours post-procedure, and that is giving time for hemostasis to occur. Highly vascular, we want to minimize risk of bleeding, so we want the patient to be still so that clots can form and decrease that risk. We're going to monitor for hematuria in the first 24 hours and monitor the vital signs for signs of bleeding or shock. So any decrease in blood pressure, increase in heart rate, decrease in consciousness, increased pain at the site, blood in the urine. And this is going to be similar to the other. You may see a little bit of blood in the urine, but it shouldn't be bright red. So monitoring the patient for flank pain and dizziness. Heavy lifting, strenuous exercise, contact course or sexual intercourse should be avoided for anywhere from days to weeks after the biopsy, depending on the patient's specific influences. All right. Oh, let me clear my stuff here. Okay, so UTIs, I'm not going to go into great detail about because Ms. Curley just covered this in your infection material. So it is caused by microorganisms in your urinary tract. We are just going to talk about it briefly since it is something that can happen there in the bladder and can cause some of these signs and symptoms that we're talking about with the elimination. So here you've got infection and elimination tied together. So signs and symptoms, that burning upon urination or dysuria, frequency, nocturia, hematuria. So remembering all those words we used earlier, and then also Ms. Curley discussed them in the infection content. So just remember that also they may be getting antibiotics to treat this, and then the peridium to help with the burning pain associated with UTI, and that can cause the orange discoloration of the urine. Now, what we are going to talk about a little bit more with elimination is the catheter-associated UTIs. So these are a common hospital-acquired infection, and they are not reimbursed unless documented on admission. So if your patient came in with a UTI, then they had a catheter, then that's okay. But if it is a hospital-acquired infection, meaning that they came in for something else, they had to have a catheter in and they got a urinary tract infection from that catheter, then the hospital will not get reimbursed for the cost of treating it. So we should only use urinary catheters when necessary. So a few reasons that we may need to is if the patient has urinary retention, they're not able to empty their bladder, if they are critically ill and we're measuring intake and output, or if there's some reason why we need very strict intake and output measurements, then that would be necessary and that would be an approved reason. Perioperatively, for certain procedures, if the patient has open sacral wounds and they're incontinent, or prolonged immobilization, also in end-of-life care, because it will improve quality at end of life if the patient's not having to be changed all the time. So strict sterile technique should be observed when inserting Foley catheter, strict sterile technique. We want to, when we're caring for somebody who has a urinary catheter in, an indwelling catheter, we want to maintain a closed drainage system. So we want to make sure that there's no leaks anywhere, that it's all staying closed. And we want to make sure it's staying not unobstructed. So if you've got your tubing, it could get kinked, it could get bent around in the bed, it could get stuck between the bed rail and the bag and the bed. So just make sure that it is draining and unobstructed at all times. We're going to remove those catheters as soon as possible. So we're going to always, every shift, be evaluating the need for those catheters. We're going to secure the catheter with an adhesive stabilizer. Stat lock is another term for it that you'll hear. But here is one here. This one's a stat lock. So actually, let me just stop my share for a second. So it would hold your catheter in place. It would go attached to your leg, close to that urinary meatus where the urine's coming out. You fit it right, the tubing on there, and then you snap this closed, and it holds that in place. So put this on first, and then position it where you need it to be on the leg, and then you would attach it. And that would keep this from pulling. If that pulls, it would keep it from pulling on the end of the catheter so that there's no tugging or trauma there to the patient. Let's see, so that's going to be important. Perineal care before the catheterization, and then every shift daily per protocol. We're going to regularly be assessing for the odor, color, amount, consistency of the urine. We're also going to be monitoring that urinary meatus where that Foley catheter is draining from, and making sure we're not getting medical device related pressure injuries or irritation there at the site. So we've got this list on your slide here for the people that are at high risk for a catheter-associated UTI. Here's our group of people who are going to be at higher risk for developing that catheter-associated UTI. Some of those things are very similar to what Ms. Curley taught you with just the UTI. So I'm not going to go into each of them in detail. So the Joint Commission puts out a list of national patient safety goals. So this preventing infections is one, preventing hospital-acquired infections is one of their goals typically every year. And so for several years, CAUTI was specifically on the list and following protocols to decrease the risk of CAUTI. So this year, for the first time in several years, when they released their list in January, they shifted the focus to hand hygiene. But it had been on there for several years before that. So that does suggest that with implementing protocols to, decrease use of, we used to catheterize everybody, but decreasing the use of urinary catheters, trying to get them out as soon as possible, having protocols in place for hygiene and cleaning and monitoring. All these things have decreased our numbers of CAUTIs. You see here, we have a chart and it is older, it's from 2013 to 2015, but that's when these protocols started coming in place. So dramatic fall, and that was just up to 2015. So we've probably continued to see a fall since then. And that's why it specifically came off the list. And so now they're focusing more on hand hygiene. But we still need to remain vigilant and protect our clients from needless hospital infections. So let's talk about a few alterations in urinary elimination. So urinary retention Urinary retention is going to be the inability to empty the bladder completely. This can be caused by several things: diabetes, tumors, stones, trauma, pregnancy, to name a few, surgery, and analgesic medications where they don't sense the need to void, or spinal cord injury can all be things that will lead to the inability to completely empty the bladder. Your assessments, when you're assessing for urinary retention, we want to assess for determining when the last void was, how often your patients are voiding, the amount they're voiding, any pain or bladder distension noted. A bladder scan that is done post-void residual bladder scan, so how much is left right after you voided, post-void residual, should reveal no more than 50 to 100 milliliters in the bladder. Complications of urinary retention are that it can lead to infection or sepsis. Nursing interventions are going to include strict eyes and nose, monitoring post-void residuals. We can do sitz baths or warm compresses to the peritoneal area can help encourage voiding. Warm beverages can also encourage voiding, and straight catheterizations if we needed to. Okay, so also urinary incontinence. So there's different types of urinary incontinence. So let's talk about that. So incontinence, just going back to, I know I said it earlier, but it just seems to get confused a lot. If your patient has the problem of incontinence, that's an elimination problem. If they're not able to control that loss of urine, where that if your body's not making urine, that's a different problem. That's a fluid balance problem. So incontinence, involuntary or uncontrolled loss of urine from the bladder. So we've got a few different types. First up, we've got stress incontinence. So stress incontinence is a result of sneezing, laughing, coughing, or changing positions. This mostly affects women who have had vaginal delivery births because of the stretching in the pelvis and lack of pelvic support after that stretching. In men, it is most often occurs after prostate cancer and can be because of a loss of urethral compression after the surgery. Urge incontinence means that you have a strong urge and it can't be suppressed. So we talked about this just a little bit ago, but patient all of a sudden it's like they don't have to go to the bathroom, and then they're aware of the urge and they can't make it to the toilet in time because after that urge happens, they can't suppress it and the body is not able to hold on to urine, and they will go ahead and have that accident. Functional incontinence is a cognitive impairment that makes it difficult for the client to get to the bathroom in time for voiding. So this is more that they're not able to make it to the bathroom when they need to void because of a cognitive impairment. So management of incontinence is going to depend on the type of incontinence and what you're going to do about it. One of the things we can do is Kegel exercises. So Kegel exercises are the most commonly used method to strengthen the pelvic floor muscles. So it will strengthen the pelvic floor muscles and are performed and found helpful for stress and urge incontinence. So basically strengthening those pelvic floor muscles, Kegel, K-E-G-E-L, is what will be encouraged there. Medication-wise, some anticholinergic medications may decrease bladder contractions and can be used for urge incontinence. This is going to include things like Detrol and Vesicare. And then they may be able to do surgery. Other nursing interventions are going to be, we're going to tell people to avoid caffeine and alcohol because they increase that diuretic effect. We're going to avoid diuretics after 4 p.m. because we to avoid nocturia and interruption in sleep patterns. We will encourage Kegel exercises, and we will encourage frequent voiding. So if somebody has urge incontinence, it will encourage them to just go ahead and go to the bathroom every 2 to 3 hours. And then whenever that urge that they shouldn't experience then that urge incontinence, hopefully, if they keep emptying their bladder regularly. And then do remember back to when we talked about the developmental changes and the elderly population, the decrease in muscle tone and things like that, that may lead to the inability of the bladder to hold on to urine. So review back also for some of those things that's what we see with our elderly population, is just those age-related changes. So let's look at some urinary devices here. So condom catheters, and that's what we've got here. The condom catheter is placed over the penis and has a drainage tube that will be connected to the collection bag. Patients may also do intermittent catheterization. So this would be a straight catheterization that is used to drain the bladder. So the patient can do this at home. This can be done for patients with spinal cord or neurologic conditions that prevent them from emptying their bladder, and are typically done using a clean technique at home. So these patients will just catheterize themselves when they're not able, since they're not able to drain their bladder on their own. Indwelling or retention catheter, Foley catheter, has a balloon inflated on the end it's placed inside of the bladder and then has a balloon inflated at the end. You do have a Foley catheter lap, so you will be getting more in this. These are used for longer periods of time. They do inside the bladder. Here's the, hold on. So you would typically fill these with sterile water, but inside the bladder, it sits, there we go, a small balloon that holds it up inside the bladder so it doesn't slide back out. Suprapubic catheters, which is what you see here, are used for longer term drainage. They're inserted surgically and diverts urine from the urethra when injury to the urethra has happened. So this is typically preferred for longer term over an indwelling catheter if somebody's going to have one indefinitely, because there's a decreased incidence of contamination and risk of infection. Another thing I just want to bring to mind as far as catheters go is with patients with prostate disorders. Hold on, I'm going to stop my share for a second again. Almost done. Okay. Okay, so this is your regular urinary catheter, and this is probably about an average size. Let's see, what is this? Yeah, 16, yep, 16 French. So that's an average size of what you see that we use for catheters in the hospital. And you see the end of it straight. So we can also use this catheter that looks like it's got kind of like a little elbow. It's got a little bend. It's a little bit more firm at the tip. Like it's just, see this hole is a little further down. So this tip is a little bit more firm. It's harder to push down, and then it's got that little curve to it. This is called a Coude catheter, C-O-U-D-E, and it is used for patients with prostate problems. Because when you're putting in a catheter, if you have a patient that has prostate problems, you may meet resistance because that urethra is compressed by the prostate and you can't get past without causing major trauma, where the Coude catheter may be able to snake through. Go back to the share. Okay. All right. And then you may see a patient that has, if they have an indwelling or suprapubic catheter, they may have a leg bag, which is instead of the drainage bags that we have at the hospital that are like this, it would be a bag that attaches to their leg so that they are more mobile. And then we've also started seeing these pure wicks inside the hospital. That's this here. I think they're pretty great. So these would be non-invasive ways to keep a good close I&O for incontinent patients and also keep their skin dry. Basically, there is a video here. You can click and watch it. It's pretty brief, but basically the soft mesh would go to the urethral opening, and then this tubing connects to suction, low intermittent suction, so that it doesn't cause trauma, but then collects the urine and draws it away from the skin. So that is going to conclude our information on urinary elimination. So if you have questions, please put them in the unit discussion forum or email me, and we'll be doing some activities in class, plus you'll be having lab to help pull all this stuff together. So let me know if you have any questions, and I hope you have a great day.